Good morning, I'm Mabel Jung, and you're watching the World Healthcare Congress Interview Zone. Thank you so much for joining us. And I have with me right now Dr. Marc Rothman, who is Chief Medical Officer at Kindred Healthcare. Good morning to you.
Good morning.
Well, thank you so much for being here. Please tell me a little bit more about Kindred.
Happy to. Kindred is a very large company. It's the largest diversified post-acute care provider in the nation. Our revenues are somewhere above $7 billion. We operate every level of the post-acute care continuum.
Wow.
From long-term acute care hospitals, of which there are about 80 or 90, skilled nursing facilities, of which there are approximately 100, and several under construction.
Wow.
Freestanding rehabilitation facilities, IRFs, about 20. We own and operate home health across the nation. We're one of the largest home health and hospice providers in the country. We take care of approximately 10,000 patients a day who are at or near the end of their lives in hospice. We are now the largest group of home-based primary care practitioners. We call that house calls medicine in 4 states, 4 markets. And we manage almost 100 rehabilitation wings or acute rehabilitation units inside other institutions. So you may not know those as Kindred even locally, but we do everything from managing the employees to the staff, hiring decisions, and sometimes the staff are our employees, but you can't always tell. And we also manage a handful of skilled nursing facilities across the country. So we are diversified.
Absolutely, absolutely. And the size is absolutely something that is large and impactful in all the communities that you serve. What are some of the programs at Kindred that would be of interest to other attendees here at the conference?
Well, there's no shortage of activity these days at Kindred. I think of most interest to folks here at the conference is probably how we are trying to move the ship, as we say, from volume to value. How do we change the nature of our relationships with referral sources, large healthcare systems, academic systems, payers, so that we're not simply viewed as a discharge destination, but more viewed as a partner in helping to manage the patient's post-acute and long-term care experience, whether that's a week in a post-acute care facility and then follow up at home, or whether that's several weeks of intense rehab for neurological problems or after trauma or gunshot wounds and things like that, or whether that's home-based primary care for people who are incredibly frail. The goal for us is really to be viewed as the entity that can help an organization manage all of that for their population. Because as we know, more and more entities are overseeing populations, whether it's 10,000 Medicare beneficiaries as part of an accountable care organization, or whether it's a payer or insurer who's now working with a state on their state-based employment programs, or whether someone's managing a new managed Medicaid program. There is a subpopulation of that population that is going to use our services.
Absolutely.
And the question that we want to pose is, do you need help managing that process? And we can do that.
And what are some of the challenges you see over the next 3 to 5 years when people are really trying to figure out how to pay for this and how to make it more efficient and make sure that people are getting the most out of the dollar spent?
Well, that's really the issue, right? And that's why, interestingly, these groups that I've been talking about that we want to partner with, they're calling us now. Because that's the question, right? How are we going to deal with a post-acute landscape that is completely fractured and fragmented, where the quality metrics are variable, and where the differences in quality measures, the specifics of those measures are very different. So you send a patient to a rehab facility, one set of quality measures spits out, you send them to a nursing home, it's different. Why is it different? That's a problem that acute care is getting out of. Their quality measures are now aligned by CMS.
So what is your answer when people do call you?
So the answer is, right, and back to your question originally, is The big challenges are, can we provide something that is more uniform? So we are working internally through our internal health information exchange and through our clinical leadership and medical leadership to hone down those quality measures and try to make them uniform as possible. We're partially doing that because the Impact Act of 2014 mandates that there be some uniformity by 2018. We've already been working on that. Our goal is to be ahead of that.
Okay.
Do we have the functional status measures for patients across the episode? So, to your point, how do they know they're getting value? Well, if the patient's inserted into the post-acute care space up here and has 2 transitions and leaves the post-acute care space from a different setting, how can the payer or the referrer source know that there was efficiency across the whole thing? That's something we have to be very, very, very good at. Our clinical programming has to be consistent. If you send us a congestive heart failure patient or a diabetic patient or a joint replacement patient, can we show you that they're getting similar care at all the sites of service, tailored to their needs, but essentially the same quality of care, the same overall design of the care? Do the patients themselves report that it all was consistent for them? So one of the programs we're doing this year is upgrading our patient experience and customer service data by going with Press Ganey. So we've signed on with Press Ganey to start doing patient experience assessment in LTAC, IRF, SNF, and home health and hospice, and home-based primary care the same.
Okay.
So that we can turn to people and say, you're getting value, look, here's the whole journey of the patient, instead of, we promise you had value at the SNF, and then, oh, by the way, here's another piece of paper that says you had value at the IRF.
Right.
And then, by the way, I'll send you a spreadsheet from home health to prove that there was value. And that is not going to be realistic in the future. And the main reason it's not realistic is because if that's how disjointed it is, how can we create the financial model? How can we create the contract with value built in if it's so disjointed? So really it's all about unifying across the continuum. We call that Continue the Care. And everything I've mentioned to you is part of the Continue the Care program.
Will that be your final takeaway for people here at the meeting this year for the message?
I think so. I think so. You know, unlike in acute care or even in primary care, so much of what we do is built around these transitions between settings, right? And so high quality transitional care, the Continue the Care programs I talked about, those are really the highlights of what we're trying to accomplish. I think the only other message I would add is we are taking a new look at how we relate to our physician workforce. The physician workforce in post-acute care has been disjointed historically, and we need their collaboration. We cannot win in a value-based world without the physicians really buying in, being incentivized perhaps to align with us, and really being leaders.
Yeah.
I said it in the panel, there has been no successful value-based program, ACO, bundled payment, any other demonstration project, without physician involvement and leadership.
Right.
And we need that at Kindred. We're taking a fresh look at how we relate to physicians. Do we educate them? Do we employ them? Do we communicate with them regularly? The old model was physicians came in and left, saw some patients and left. And that's just not going to be sustainable going forward.
Okay, Dr. Rothman, we're going to leave it there. So thank you so much for your time today.
A pleasure. Thanks for having me.
And I'm Mabel Jong. Thanks for watching.